Good afternoon, everyone. I welcome you all on behalf of Department of Radiation Oncology, and I welcome all those senior professors and my colleagues. Today, we will be presenting a rare case of residual non-seminomatous germ cell tumor treated with stereotactic body radiotherapy. This is the first case in the world where we have used stereotactic body radiotherapy to treat a residual non-seminomatous germ cell tumor. Uh, the residual non-seminomatous germ cell tumor usually is a mature teratoma, and it is very radio resistant, and not very encouraging results have been produced. So the treatment option is generally surgery. We utilize this SBRT, which is a very precise and a very conformal form of radiation therapy. So it helps us in escalating the dose while minimizing damage to the normal tissue, and it delivers a very high dose of ablative radiotherapy. So it's different from the normal radiotherapy where we give 2 gray per fractions, but in stereotactic body radiotherapy with sharp localization, we kind of give very ablative doses to the tumor, which is normally 7 grays to 20 grays per fraction. And if we miss the target, then there are very high chances of toxicity and damage to the adjoining structures. So, not taking much of the time. This case will be presented by Dr. Abhilash, junior resident from Department of Radiation Oncology, and the SBRT process will be discussed by Dr. Shwetima, senior resident in Department of Radiation Oncology. May I now call upon Dr. Abhilash to present the case. Thank you.
Thank you, sir, for the introduction. Good afternoon, all. I'd like to present the case. This is a 23-year-old gentleman with EGOG performance status 1 without any comorbidities and without any family history of malignancy. He presented at an outside private center with a painless left testicular swelling since last 2 months. A ultrasound of left testis done outside was suggestive of a heteroechoic lesion 4.2 into 2.3 centimeter in left testicle and adjacent left epididymis involving the left spermatic cord also, with minimally inflammatory, minimal hydrocele was also present. A screening USG whole abdomen was done at outside center, which did not suggest any abnormality. Uh, the, the patient underwent left inguinal orchidectomy at outside private center. The primary histopathology done outside was suggestive of embryonal carcinoma of the testis. The post-op tumor markers done were not elevated. A patient was on regular follow-up at outside center. Post-op CECT abdomen and chest did not show any disease. On routine follow-up, patient underwent a USG abdomen around 3 months post-op, which suggested a well-defined hypoechoic mass around 4 into 2.5 into 2 centimeter, 14 cc in volume in epigastric paraumbilical quadrant in retroperitoneum, abutting the left lateral margin of the abdominal aorta. Tumor markers done 3 months post-op were about 3 times higher than the baseline. Patient self-referred himself to National Cancer Institute for further management. The patient was evaluated at the Department of Medical Oncology at NCI. Our patient was advised block review at AIIMS and a CECT abdomen and pelvis. The block review at AIIMS revealed non-seminomatous mixed germ cell tumor with yolk sac and embryonal carcinoma components. IHC was done, SAL4, CK, CD30 and CDX2 were positive and EMA was negative. A CECT abdomen and pelvis done at National Cancer Institute was suggestive of 5 into 4.5 centimeter, a left paraortic lymph node abutting the left renal artery and vein. They were seen traversing tangentially through the superior and inferior surface of the node. A USG guided FNSC was planned from the nodal mass, which was suggestive of metastatic germ cell tumor, cell 4 positive and PLAPAS focally positive. So final impression was mixed non-seminomatous germ cell tumor stage 2C. The case was discussed in the tumor board and the patient was explained about the risk of infertility and was advised sperm preservation, but the patient opted against it. Then after discussion, the patient was planned for 3 cycles of BEP. CECT abdomen done 1 month post 3 cycles of BEP suggested a partial response in the mass. The mass was of size 2.7 into 2.5 centimeter in the left paraiotic location, displacing the left renal vein superiorly and left renal artery inferiorly with decrease in size. As you can see, this is the mass which is very close in relation to the bowel and to the kidney. So the patient was evaluated outside. He did not have any films or CDs available with him. So the impression was partial response. Patient was planned for salvage surgery in view of residual disease post chemotherapy. Patient required resection of the renal vessels or R0 resection as the lesion was encasing the renal vessels. In view of patient not willing for major operation and the ongoing COVID pandemic, the option of SBRT was explored. Patient was informed that SBRT has been effective at other sites but has not been explored for residual non-seminomatous germ cell tumors. Our patient was explained the risk and benefits associated with the procedure that included fatal bowel hemorrhage, stenosis, injury to renal vessels, kidney and other adjoining organs. So for the residual mass, the patient was planned for stereotactic body radiotherapy and the dose planned was 42 grains 7 fractions. So what is SBRT? It's a relatively new technique that permits delivery of very high doses of radiation with high precision with image guidance. So it is increasingly used as an effective alternative to surgery for various subsites like lung and prostate. The standard of care in non-seminomatous germ cell tumor is surgery followed by adjuvant chemotherapy and salvage chemotherapy followed by surgery in case of locoregional recurrence or residual disease. The use of radiotherapy in non-seminomatous germ cell tumor, it has been limited based on the preliminary data suggesting poor response to conventional fractionation. So this challenges our notion that the non-seminomatous tumors are radio resistant. The thing is that they are radio resistant to conventional fractionation, not to very high ablative doses. So radio resistant at conventional fractionation and delivery of radiation was particularly challenging given the radio resistant nature of the residual disease and close proximity to critical organs. Currently, advances being made in imaging and radiotherapy now allows for highly conformal dose escalation while reducing exposure to nearby vital organs. These are the various retrospective analysis done in non-seminomatous germ cell tumor, evaluating the role of radiotherapy. There has been two case reports where SBRT has been used. In one case, the location was a lung mass where they utilized the dose of 54 grade 3 fractions, and one was pericardiac location where he utilized 50 grain 5 fractions. So now I would like to call Dr. Shwetima to walk you through the workflow of SBRT.
Thank you, Dr. Abhilash, for taking us through the case scenario. Good afternoon, everyone. I will be taking you to the workflow of the SBRT that is being done in our department. So these are the various steps, including the immobilization, 4D cone beam CT, target delineation, OAR is organs at risk delineation, volumetric mediated arc therapy planning, followed by evaluation of dose to target and normal structures. The organs at risk dose volume constraints are used, followed by plan approval, daily cone beam CT matching before treatment and during treatment, and various challenges that are faced during daily motion of adjoining bowel. So I'll be going one by one. In the first figure, we can see this is the abdominal compression, and in the second figure is the blue body bag, which is known as VACLOG. This is an immobilization device where we use for positioning of the patient so that we can do the CT simulation for our planning purpose. Along with the blue bag, there is a belt which is used for the abdominal compression to restrict the daily movement of the abdomen, and we wrap it around the abdomen, and along with the adequate pressure is applied with a pressure gauge. These are the three figures how we start our planning. The first day when the patient came, we make a backlog, a blue bag, where a patient is being positioned. We wrap the abdominal compression. There is a hand rest placed behind the head of the patient. So in the second figure, we can see that the patient is being positioned in this way. In the third figure, this is our CT simulator and the patient is being taken inside it, followed by we take 2 slices from the CT. So 4D CT records the multiple images over time and it allows the playback of the scan as a video so that physiological processes can be seen and internal motion can be tracked. So we are going through the first session, that is pre-SBRT. This is the first day when the patient came to us and we take the scan of the patient. So this is the scan. After taking the scan, this image is being transferred to our treatment planning system and where we contour and delineate our target as well as our organs at risk. So this is a small video which is showing two circles. One is the yellow and the other is the red circle. The yellow is showing the gross tumor volume followed by a red circle which is showing the planning target volume, which is very limited to the gross tumor volume. So this is the way we are delineating the tumor. So slice by slice, we are delineating this in each and every slice of 2 thickness till the last slice of the tumor. This is the image which we see on our treatment planning system while we do the contouring in 3 sections. One is the axial, sagittal and coronal section. In all the 3 sections we used to contour and we see that our target should not be missed. These are the delineation of different organs at risk. The blue line is showing the large bowel, the yellow is showing the small bowel, and this is the kidney and the abdominal aorta. So we have to see that the PTV margin, which is the planning target volume, it is touching the bowel as well as the aorta and it is just near the kidney. This is the planning which is being done by the physicist and this is the arc which is used to show the reason that we have to treat. So we can see that the part that is being treated is mainly present on the left side and we are sparing the part which is not involved by the tumor. This is the 80% coverage of the tumor volume. After planning, we can see that part of the 50% coverage is being shown by the is going towards the bowel. Although 100% of the 100% of the dose is being prescribed to the target, but because of the adjoining structures are present, like the large bowel, the kidney, so some of the part has been underdosed at this place. This is a 50% coverage showing that low dose region is shown by the blue and the target is mainly towards the near the red area. So we can see that the part of the bowel is irradiated and low dose region is getting it, but it is highly conformal. Now when the patient is planned, the plan is being approved, followed by it is being sent to the machine where the treatment area, where the patient is being given the treatment. So the first day of the patient, when the patient is being lied down on a couch, we again use the same setup the first day when the patient came for the simulation. So this is the video. This video is showing that we can see that there are two scans. One scan that we have taken at the time of simulation before planning, and the other scan is at the time just before the treatment, so that we can match bone with bone and the PTV with PTV, and also the vessels are matched. So we can see that there is a moving window. The scan that is taken at just before the treatment is this, and the scan at the time of simulation is this. So we can see that there is a conformity, and the bone are matched with the previous as well as just before the treatment. After matching, the patient is being delivered, the dose is being delivered to the patient. This is the motion of the how the gantry is being rotated. Along with this, we have given certain dose constraints to the spine, to bowel bag, to kidney, and to aorta. And we can see that these are the dose constraints that have been given. And the dose that we have achieved is that we can see that all the dose constraints have been achieved. Here is a video showing a comparison between the pre-SBRT and a post-SBRT. In the first video, we can see the gross tumor volume as I have shown it earlier, along with a PTV. And in the second video, we can see that the part where the tumor was present has been replaced by the bowel. So this was the scan has been taken 3 months post-treatment. This is the scan being taken post-treatment 3 months. We can see some part of the bowel is being inside it, and some fibrosis can be seen. This is at the time of just before the treatment, and this is 3 months post-treatment. Followed by, we have also seen the response in the tumor markers. When the patient came to us at 3 months post-op, we can see that the alpha fetoprotein levels are almost 2 times were there, and the LDH markers were raised almost 3 to 4 times. And on subsequent follow-up, pre-SBRT and post-SBRT 2 months, there is a falling trend in the tumor markers and have been normalized. So post 1 year, we have the results. So conclusion is the stereotactic ablative radiotherapy may represent a novel therapeutic option for patients with such extenuating circumstances. More number of patients and a longer follow-up is required to assess the treatment efficacy and late toxicities. At present, when we followed the patient remains disease-free without any symptoms post 1 year and has tolerated treatment well without any acute or long-term complications. With this, I would like to end my presentation. Thank you. I would like to invite Dr. Aman sir to enlighten further on this.
Thank you, Dr. Shwetima, for the wonderful presentation. If there are any questions, I'll be more than happy to answer the queries, and with my limited knowledge, and do pardon me if I'm not able to answer all of them. Sir, the patient is on regular follow-up. He is not even developed grade 1 acute or late toxicities, and this was very encouraging for us. And such a radio-resistant tumor responded very well to a high dose of radiation. So not even grade 1 is normal. Normal. Yeah. Everything is fine, sir, but maybe there could be late toxicity which can happen on subsequent follow-ups. Normally, sir, we are just doing a KFT by now, and sir, the kidney has not received such a dose that the function would be compromised. The vessels, the renal vessels would be at risk. but it's too early to comment on the vessels. The D mean of the kidney was like very less. It was far away from the gradient. For us, bowel is the more important toxicity because it was overlapping with the PTV. Kidney was quite far away, and it even did not touch the 50% isodose line. So yes, yes, if by those, no, no, sir, no, no, sir, no, no, only KFT, nothing else, sir. Agreed, 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 sir. Sir, sir, I think we can consider this. It's a good input. We'll go and get back again. We have not done it. We were not expecting it, but keeping your inputs in mind, we'll do the function scan. And also, I think there are chances of stenosis to the vessels, which will happen a bit late. The radiation-induced vasculopathy will take about 3 to 5 years normally, but it can happen early also. Your comments are well taken, and we'll get back with the scan. We'll advise it. Thank you, sir. If there are any other questions, yes, sir. This is a risk. Of course, this is a risk because the follow-up is just 1 year. As of now, he is not even developed any minor symptoms also. But this patient has to be tracked for a few years. He's young, and we'll have to check in. And we have, because there was an overlap of the bowel, we kind of underdosed it. We met our constraints, but then the bowel moves daily. So it's good in a way and bad in a way. So if the ball was very close, we did not deliver the fraction on that day. So we like, being a radiation on, so this is not the first line of treatment, but sir, also it required maybe sacrifice of the renal vessels for R0 resection. So because this is a single case, not much can be conclusion can be drawn, but like we have a history of organ preservation, and wherever we have done the trials, we've always won. So I firmly believe that if we do a trial, we would win, provided we do not produce late toxicity. And late toxicity also comes in the surgery also, adhesions and all those things. So patients have to be followed up. This is too early to comment on anything. Till now we should follow the standard of care, which is surgery, sir. Sir, sir, I think I can have the answer is, if the patient is not willing for surgery for any reasons, is not fit for surgery, then we'll explore this option. And if we have good data, say 50, 100 patients, then we can think, not now. Yes, sir. That is what we are concluding. We just have one case, and we have concluded that more number of patients are required. But because we did something very unique for the first time in the world, so we thought of sharing it with you. Thank you, sir. Any, no, so normally, sir, they are the standard of care is chemo, and then if there's a residual tumor, then they go for surgery. But it was a COVID pandemic, and vessels had to be sacrificed. So both ways, the patient was not willing. So we thought we'll explore, and we were also not very sure because this is a radio-resistant tumor. But we tried, and the results were encouraging. If there are any other questions, If there are others, sir, I'll be more than happy to answer. Thank you very much. Then we can move on to the next presentation. Thank you, everyone.
Next, a very good afternoon to all of you. We have a case from RP Center, and we have a case of a Marfan syndrome with a subluxated lens. And the reason why we are presenting this case is that in a case of Marfan's, we need a CCR. Go to CCR. Yeah, then presentation one. Come to presentation one. And in a case of Marfan syndrome, you need a multidisciplinary approach. And that's the reason why we wanted to present this case. And these patients need meticulous evaluation and good follow-up at a, after even after the surgery and even after, medical evaluation initially. So we would first present the case, and then, of course, a little bit of discussion will be there. We would also like to have the anesthetist, anesthetic consideration, because many of these cases are children who come to us with subluxated lens. And there, the role of anesthetist is vital, because he not only evaluates the patient, also suggests us what investigations needs to be done, how or what all evaluation needs to be done. So first, I would like to invite Dr. Afreen Bari, senior resident at RP Center, and she will be presenting the case, which we have labeled ECLIPSE in the eye, a terminology coined by Chief RPC.
Good afternoon, one and all. Today I'll be presenting the case for the title Eclipse in the Eye. The outline of my presentation I'll be first discussing the history, related ocular and systemic examination, then the investigation, then we'll discuss the management of this particular case, followed by the discussion, and then we'll be taking our take-home messages. A 21-year-old male presented with blurred vision in both eyes since childhood. It was insidious in onset, painless and progressive in nature. He was a student who had been using glasses for the last 7 years. There was no history of previous trauma or surgery. He had no known systemic illness. On inquiring, we got to know that he also had similar complaints in the family. His younger brother was affected in a similar way, and his mother and maternal uncle also had similar problems. On general examination, he had good build and nutrition. Pulse and blood pressure were within normal limits. We examined the patient based on various systems, cardiovascular system, respiratory system, neurological system, all were within normal limits. There was no abnormality or any deficits. Then on physical examination, the patient had tall stature. We took out the arm span is to height ratio as shown in the figure, and this was around 1.01. We also calculated the upper segment is to lower segment ratio, which was 1.07. Patient had thin, slender hands, which suggested of arachnodactyly. The patient also had positive thumb sign. So trying to fit it into the for the score calculation, as in the modified Ghent's criteria, the patient just had 2 positive scores, which was for the thumb sign and myopia more than 3 diopter. So he was not, he got score of 2. Coming to the ocular examination, his best corrected vision in the right eye was 6/18 and in the left eye was 6/12, and near vision was N18 and N12 in the left eye. In the undilated state as well as dilated state, we all examined the patient. In the undilated state, we saw that in the right eye, the lens was bisecting the pupil and it was a clear lens, while in the left eye, there was phakic zone in the pupillary zone in the undilated state. On pupillary dilation, we saw that in both the eyes, there was clear lens. Both were supranosal subluxated in dilated state. Coming to various differential diagnosis for ectopia lentis. First of all, first differential was Marfan syndrome. The points in favor was that the subluxation was superior, the nature of inheritance was autosomal dominant, the tall stature with positive thumb sign went in favor of the Marfan syndrome, and even the zonules were stretched, they were not absent. While points against were the patient was also examined and his echo reports were normal. So normal echo went against it, and even the systemic score could not reach relevance. The score was just 2. Other differentials were homocystinuria. Points in favor was bilateral symmetrical subluxation. However, superior subluxation is not typical of homocystinuria. Usually we see inferior subluxation. Broken zonules were not there. Patient had normal IQ. We also got serum homocysteine levels which were normal. Traumatic subluxation was also not considered because the patient did not give any history of trauma and there were no signs suggestive of any closed globe injury. Coming to the patient examination, we did refraction for the patient. Refraction in such cases can be done in aphakic zones as well as in phakic zones. The best vision that we could get doing the refraction in the phakic zone was 6/18 in the right eye and 6/12 in the left eye. We did biometry for this patient using ILMaster. The patient was myopic. His axial length was 27.5 and 27.45 in both the eyes respectively. Anterior chamber was relatively deep. Systemic investigations, we did the general blood test, complete blood count, liver function and kidney function tests. All were within normal limit. Chest X-ray, no abnormality was seen. 2D echo was done, which showed that there was no abnormality. Genetic evaluation then was done for the patient, which confirmed that there was fibrillin gene mutation on chromosome number 15. Serum homocysteine levels were within normal limit. Urine homocysteine level was negative. So with this, using the revised Ghent nosology, we made the diagnosis of Marfan syndrome with bilateral ectopia lentis. Coming to the management part, first the ocular management. For this case, surgery was planned. Both eye intralenticular lens aspiration with scleral fixation of the lens was planned under peribulbar anesthesia. As we can see here, the patient is under peribulbar anesthesia. Localized peritomy is done, and on nasal as well as temporal side, after the localized peritomy, scleral flaps are made. The flaps are made around 1.5 mm marks from the limbus. Here we can see that using the crescent, after the flaps are made, then using 2 microvitreoretinal blades, which are of 1 mm width, the lens capsule is punctured at angles which might be comfortable to the surgeon. Now at these 2 entries, first using irrigation probe, the lens is stabilized, then the aspiration probe is used to aspirate all the lens matter. After the lens matter is aspirated, a vitrectomy cutter is used to remove the bag remnant as well as do limited anterior vitrectomy. After this, through the flaps, the entry is made for the scleral fixation of the haptics. A superior 3.2 entry is made for injecting the 3-piece acrylic lens. After the leading haptic is injected through the scleral fixated IOL forceps, it is exteriorized out and one side is fixated, while the other trailing haptic is thereafter fixed in the other scleral pocket using the handshake technique. This helps in ensuring that the IOL is well centered and it is fixed properly at in both the scleral tunnels. Once we ensure that the superior wound is closed and any remnant vitreous is removed, the wound is sutured with 10-0 MNF and the peritomy as well as the flaps both are closed in sequence. This method of intralenticular bimanual irrigation aspiration was first described by Professor Rajesh Sinha only, which is a very less kind of atraumatic technique for removal of the lens. A modified technique has also been described from the center, which advises the use of endocapsular lens aspiration through the cutter mode. Now, post-operatively, the patient was prescribed topical antibiotics, moxifloxacin 3 times a day for a month in both eyes, and topical prednisolone 4 times a day, and it was weekly tapered. Visual acuity in the right eye was 6 by 18, in the left eye was 6 by 12, and both eyes had well-centered scleral fixated IOL. Coming to this was only the ocular surgical management. Now coming to the ocular screening, we screened all the family members and gave them the options of visual rehabilitation if they were involved. The case mother had undergone bilateral cataract surgery 30 years back and was using phakic glasses. We gave her the option of removing the glasses and getting the surgery done. And the younger sibling also had ectopia lentis and was using myopic glasses. We also advised him what were his options. Then counseling was done. The patient was explained about the potential in both the eyes for distance visual acuity. All the advantages and risks associated with surgery was told preoperatively only. Additionally, we also explained him the risks associated with high myopia. Since he was a student, we told him that he will have to use near glasses post-operatively also for his near work, and he needs to follow up with us regularly. Coming to the systemic management, all involved family members were also advised to get the detailed systemic evaluation. Counseling was done regarding the genetic association of Marfan's and it being autosomal dominant, that there is risk in future generation. Thank you. Now the discussion part will be taken over by Rajesh sir.
Thank you, Dr. Afreen, and as I said, that this is a case which we do encounter in our day-to-day practice, and the terminology is really nice. I really liked it. The eclipse in the eye, and I guess Titya sir must have thought why we call it eclipse in the eye, because you can see the shapes of the crystalline lens, how it changes with different grades of subluxation, and it looks very much like an eclipse. So that's the reason. Now, I'll just tell you why, what all happens. Now, normally in an eye, we have a crystalline lens, which is right in the center of the eye. And this is a major refractive apparatus apart from cornea. So the rays are refracted and they get focused onto the macula, and that gives a crisp and clear vision once the patient to everyone. But if the lens is not there, then this patient becomes high hyperope and the rays are focused behind. So as you can see here, with the clarity of vision like this, if the lens is bang in center and the patient is emmetrope, if the patient becomes aphakic, the blurring of vision is seen. Now, if the lens is decentered, it's not in the center, it's somewhere here. So part of the rays will be refracted from the aphakic zone and part from the crystalline lens and also from the peripheral part of the lens. So it will have irregular astigmatism resulting in different kinds of visual disturbance. Will have prismatic effect that will also cause visual disturbances. And that is why we cannot retain the crystalline lens in this manner. We have to either bring the capsule in the center and place something so as to cover up for the refractive loss if we remove the crystalline lens, or we have to remove this and do something else, put some alternative. Now there are various causes, and so many causes have been labeled in the literature, and the major causes are Marfan's, homocystinuria, Weil-Marchesani, etc. And we do investigate for all these different systemic conditions. So the patient comes to the department, to our center, to an ophthalmologist, but this patient requires attention of multiple departments, not just ophthalmology. It requires attention of general medicine, cardiology, genetics, pulmonology, pediatrics, neurology, everywhere. So for the attention of all these, it is very essential to have a good planning. And the aim of management of this patient is to provide good ophthalmic care. Apart from that, the issues related to the musculoskeletal system, cardiac system, the genetics, other systemic issues, all needs to be handled, because we can't just manage the ocular part and leave the patient like that. And of course, if GA is required, then anesthetist is required. And anesthetist is the best friend that way, because he advises us what all systemic evaluation needs to be done. So the ophthalmic care, as has been very nicely discussed by Dr. Afreen, was the management of subluxated crystalline lens. And see, as I told you, that if the lens is subluxated on one side, it is not in the center. So it has to be either brought in the center or something else has to be done. And for that, we need to grade the degree of subluxation, because there will be mild subluxation, something like this, with this much of crescent. There can be, moderate subluxation, and there can be severe subluxation. Now, if you have a mild subluxation, something like less than 4 clock hours, then you can go ahead, do a lens aspiration, and endocapsular ring can maintain the capsular bag in its position, and you can place an intraocular lens in position. So the idea is to keep the bag in center so that you can place an intraocular lens in the bag, so that the refractive apparatus, which is replacing the crystalline lens, is bang in the center. If there is more subluxation, then you have to actually fix the bag with a Sionese ring. And if there's more severe degree of subluxation, as has been shown in the video by Dr. Afreen, you have to remove the lens and do a scleral fixation of IOL. Now, if you have a very small degree of subluxation, something like this, then in such a case, it's not running. It's not running yet. Chalo. Back job, back. Ensure. No, it's there. Back, back, escape. So if you have a subluxation of only this much, in such a case, you can just make an anterior capsular opening, remove the lens matter, and put a ring which stretches the bag and keeps it in position. Now, if the subluxation is a bit more, something like this, then you have to fix that ring transclerally so as to maintain the capsular bag in position. And if the subluxation is furthermore, which has been shown by just now Dr. Afreen, so I'll skip this video. So in such a case, you have to remove the whole of this lens along with the capsule and then fix the a lens intrasclerally. So the take-home message in these cases, in cases of Marfan syndrome, is that you have to do surgical correction for ectopia lentis, depending upon the degree of severity of subluxation, and thorough evaluation of the patient, referral to the specialists in various departments, depending upon what different departments can be involved, what other organs and systems can be involved, we have to do. Treatment strategy depends on the extent of subluxation, as I said earlier, and follow-up in the post-op period is essential, because we need to know how the patient is faring, because these patients are at risk for some other problem as well, something like retinal detachment. So these patients have to be followed up. And a multidisciplinary approach is essential for overall management of the patient, not just ophthalmic, but that is an indicator that this patient might be having various other problems like cardiological problems, like musculoskeletal problems. So a multidisciplinary approach is essential for the overall management, and there's a special role of anesthesiologist who not only guides us to evaluate the patient, but many times required for performing the surgery under general anesthesia. So I'll request Dr. Arshad to give us the anesthetic perspective of managing the cases of Marfan syndrome.
Thanks sir, for the lovely introduction. I'm here to now give you a brief overview about how we as an anesthetist approach in a patient for ectopia lentis in the pediatric population. Or when we get a patient of ectopia lentis, the focus is not on the ectopia lentis, but it's actually on the etiology of the ectopia lentis. So we are basically focused on the three congenital anomalies. Number one, Marfan syndrome. Number two, homocystinuria, and number three, Wales-Marchesani syndrome. Now coming on to our first case, that is the Marfan syndrome. What is defective in the Marfan's? So Marfan syndrome, there is a defective in the fibrillin, which leads to the defect in the elastic matrix protein, which leads to the laxity of the tonsil stent and the elasticity of the connective tissue. So it affects various systemic disorders. But as an anesthetist, we are focused on three things. Number one, cardiovascular. Number two, respiratory, and number third, our best thing is that the airway. So coming on to the cardiovascular thing, what are the manifestation? Once there is a laxity of the elastic protein in the tunica media of the vessels, there is a thing called systemic medial necrosis, which leads to the aortic dilation. This is the most common manifestation, leading to almost if I find in 60 to 80% of the cases. So this is a very important thing. That is the aortic dilation. Number second thing is that the valvular laxity, which can lead to the MVP or the MR of the patient. So how do we approach these patients? Number one, since serious manifestations are the most common, it is HH14, the guideline at all a class of recovery, that is the one that all of the patient with Marfan syndrome has to go a pre-operative echocardiography for the evaluation, because the incidence of aortic dilation is around 60 to 80%. That's quite a big one, and MR is almost like 50 to 80%. So it is recommended to get a pre-operative echo. So how do we approach a patient of aortic dilation? In the preoperative phase, the basic idea of management of aortic dilation or the aortic aneurysm is to decrease the stress on the aorta. How do we decrease the stress on the aorta? By decreasing the force of strength on the aorta. So as to what that do, how? By decreasing the force of contraction of the heart and control of the BP. So how do we decrease the force of the contraction of the heart? By beta blockers, the first drug of choice. And what else? If the BP is still not yet controlled, then we should go for calcium channel blocker, ACE inhibitor, or the ARB inhibitors. But if anyhow aortic root diameter is more than 5 centimeter, or if the growth or the dilation of the aorta is more than 0.5 centimeter per year, so we should go a surgical intervention or a stent repair. So always get a pre-operative echo done, a Doppler echo, so to start the beta blockers after the consultation with the cardiologist. Similarly with the MR, the idea is to decrease the LV volume overload, and if there is a patient is asymptomatic, no active intervention is required. But if there is a sign and symptoms of the arrhythmias, get a cardiologist consultation done, get an ECG done, and start the patient on the beta blockers ASAP. Supposedly, if the patient has decreased meds, if the patient is not able to walk, is not able to do his daily activity, is not able to walk one flight of stairs, patient should be started on the diuretics by a cardiologist. But if anyhow, if the patient has chest cramps, patient, you can see patient is dizzying at rest, patient has not able to breathe, then you should get a surgery done as soon as this possible. This is according to the HA guidelines 2017. So how do we manage these patients intraoperatively? The idea is to prevent the hemodynamic stress to the aorta. So prevent the intubation response, decrease the separation anxiety. The child should not be crying aloud. So the child should be given a pre-medication. Intubation response should be to prevented, and anesthesia and analgesia should be there to prevent the hemodynamic response and prevent the stress response to the aorta. So what are the goals in the MR? MR, the idea of the goal is to decrease the volume overload and to allow the forward stroke volume to go from the LV to the systemic circulation. How can we do that? Number one, prevent volume overload. Do a conservative fluid therapy. Do not keep on giving fluids and blood to the patient. Number second thing, to increase the forward stroke volume, you have to decrease the systemic vascular resistance. Otherwise, the blood will flow back into the LA. from LV to LA. And since these patients are chronic patient on the left ventricular volume overload, always prevent myocardial depression. So coming on to the cardiovascular, from the cardiovascular to the airway consideration, you can see the airway problems are two pronged. Number one, the airway, and number two, lax cervical joint. In the airway, you can see there is a high arch palate, there is a clouding of teeth. So a basic insertion of LMA and the laryngoscopy becomes difficult. And lax cervical joint, you cannot extend the neck for the LMA insertion or the intubation. So what is the option? Option is a supraglottic insertion along the base of the tongue without extension, so that we can use a preformed supraglottic airway device. Many preformed supraglottic airway devices are available, like EMBO LMA, Toprosi LMA with an introducer, or an iGel. Coming from the airway, what are the respiratory combination and third and the phlegm? If the elastic tissues are deficient in the alveoli, it might lead to the emphysema, which can lead to the pneumothorax. Mind it, the incidence of spontaneous pneumothorax in Marfan syndrome is almost like 5 to 10%, so it's not less. Plus, since these patients have emphysema, they are more prone to have recurrent infections, so they might have a reactive airway disease. So we have to, these patients might to present as obstructive lung. Second thing, they might have a spinal deformity, which we can to present as pectus carinatum or excavatum, as well as thoracic kyphoscoliosis, which can lead to the restrictive lung disease. So there's a picture could be both of obstructive lung disease as well as restrictive lung disease. How do we approach them? If you find there's a symptom of obstructive lung disease, there's a symptom of wheezing, rhonchi, or patient is dizzying at rest, you should take a history, start patient on bronchodilators, get a chest X-ray done, and PFTs. PFTs are a bit controversial. You know why? Because PFT are done according to a reference value, and that is based on the height of the patient. So if the height of these Marfan syndrome patients are high or increased, they might get a wrong PFTs. So what is the solution? A standing PFT, a sitting PFT can be done in this. So intraoperatively, we should keep airway pressure in check, maintain adequate depth of the anesthesia, and an anesthetic agent with the bronchodilator effect is advocated. Coming on to the restrictive lung disease, as you can see, this is a patient of pectus carinatum, and this is a patient of thoracic kyphoscoliosis. These patients might have a restrictive lung disease. In this such patient, depending on the severity of the disease and the deformities, if you can find a deformity, you should advise the patient for a PFT, ABG, and an echo if the deformity is very, very severe. Otherwise, echo is not recommended. So intraoperatively, we ensure adequate ventilation. Hypothermia and hypoxia has to be prevented. And if the disease is very, very severe, patient might need a postoperative ventilation. So this is all about the Marfan syndrome. There are now a few words about the other etiologies. For one of the homocystinuria. Homocystinuria anesthetic considerations are based on two things. Number one, hypocoagulable state, and number second thing, hypoglycemia. These patients are hypocoagulable, but many of these are the pediatrics which we take care of, and hypocoagulable state and the DVT is more common in the adults. So, do we recommend pharmacological or mechanical means for the DVT prophylaxis for these two patients? No. Why? Because according to the DVT prophylaxis and the pediatric anesthesia regimen, all operations which are less than 30 minutes and in which the patient can be ambulated early, do not need a pharmacological or mechanical interventions. So other problem is that the hypoglycemia. These patients have increased insulin level in their body because of increased methionine levels. So these patients are more prone for hypoglycemia. So what should we do? We should post them early as possible. Number second thing, 4-hourly sugar charting. And now there is a new thing called ERAS protocol, which advocates that the oral dextrose can be given even 1 to 2 hours before the operations. And this doesn't affect the patient and helps the patient for the early recovery and good discharge. Last is the very rare thing, which is a Weil-McChesney syndrome. It has basically cardiovascular, airway, and the ocular issues. In the airway, again, airway is difficult, which makes, and the neck joints are on the opposite side of the Marfan syndrome. There the neck joints are stiff. Again, it makes laryngoscopy difficult and LMA insertion are difficult. So what is the option? We can use angulated blades, we can use intubation adjuncts, and we can intubate the patient with a preformed supraglottic airway device, which doesn't need atlantoaxial extension or the neck extension. Coming onto the cardiac, again the patient might have MR, which have the similar goals. We have to decrease the left ventricular volume overload, decrease the SBR2 to encourage the forward stroke volume of the patient and maintain the good heart rate, because there is a decreased cardiac output. So to maintain the cardiac output, so there is a decreased stroke volume. So to maintain a cardiac output, you have to increase the heart rate. Cardiac output is equal to heart rate into stroke volume. So, and the tachyarrhythmia goal, we have to get a preoperative ECG done, accurate assessment has to be done, and intraoperatively you have to prevent any symmetric response. Thanks. All welcome for any queries.
Thank you, Dr. Arshad. Any question, any point that you would like to raise? Any question?
In anesthesia part, did you face any difficult situation? You've been in an RP center for an hour.
Sir, ये pictures,
you were the one who handled all these pediatric patients.
sir, ये pictures आज ही के हैं.
That is one patient, but any difficult situation you have faced?
Yes, sir.
in the management of these
Yes, sir.
patients?
All these two patients have MR. Most of them have aortic aneurysm or dilation. So these are high risk to patient. Second thing, chest wall deformities are also very common. So although we have not yet faced so many airway difficulties, and the biggest saving grace is the operation time. The operation time is bullet, and we really don't have to intubate the patient many a times. So the difficult airway things and the operation time makes our works easier.
Thank you. Dr. Afrin, this patient had a 6/18 vision with your refraction through phakic area, and post-op also patient has 6/18 vision only. Why this patient has not improved beyond that? Early post-op we have not.
When was the
The
induced?
Sir, the patient had been using glasses, started using glasses at the age of 15 years. He and was a high myopic patient. So there is certain amount of vision loss that has already taken place by that time before he started using glasses. So that is why not everything can be recovered. That is why we have counseled him that his best corrected distance vision was 6/18 only.
I think that's a very important point. Sometimes these pediatric patients, they come quite early with the presentation to the hospital. If you correct them at that stage, we can avoid amblyopia in these cases. And this patient came to us at the age of 21. So by the time already amblyopia has set in, and we can't do much beyond that. That's why, though it's a rare disorder, but not very uncommon in an institution like ours, where people come with a lot of referrals. I've seen patients coming to us through cardiologists. They've gone to cardiologist first, then came to RP center later. So that is a scenario. So it has to be, the parents has to be educated in a pediatric group where they should see their kids are using myopic glasses and the repeated change happening with more addition of power. That means there's something wrong beyond the routine refractive error. So that is a very important lesson to not only to parents, maybe other people who are treating pediatric group of patients. So that is very important. I think that's why I wanted to highlight the vision has not improved despite or such a massive effort.
The quality of vision, sir, will be much better with the pseudophakic eye in comparison to a lens which is bisecting the pupil, wherein there will be a lot of aberrations because of that.
In that connection, you showed those pictures were very impressive, where you showed that tree in the scenery and how it would change with the degree of subluxation of the lens. How are those images created? Do you have any idea? Did you get them from another? So how do we know that this is what the child with a subluxated lens is looking at? The distortion you showed?
Yeah.
A set of 4 images.
Yeah, no, that's very true. You cannot quantify exactly that this much of subluxation will have exactly this much of visual disturbance, but it is just a assumption that with this kind of an aberration, which is measured on the machines, sometimes we get a simulated picture of what kind of an image will be created on the retina.
So it's a computer simulation.
Yeah, simulated. Yeah.
You made that really brought the point home very well.
Yeah, the reason was this only, that we just wanted to show that why exactly we need to shift the capsular bag in the center, because if it's not in the center, it will create all these kinds of distortions and
But we do have, we can measure the entire aberration of the eye.
yeah.
We have a machine, we can measure the total aberration profile for eye. It tells you what a aberration patient. We have a lower order, higher order aberrations of the eye because it's like a refractive apparatus. So our systems can measure those. Then we know that how much is aberration, and that aberration, how much distortion image can be picked up also by a machine. So those we have.
Another point we just wanted to highlight was that for an ophthalmologist, if a subluxated lens comes, even if somebody who is 21 years of age, he should not just be treated like an ophthalmic case. He should be treated like a complete case with, he might be having multiple systemic problems. And if such patient goes to any other department with a case of Marfan's or anything, then ophthalmic evaluation needs to be done, because these patients might be having a lot of ophthalmic issues. Yeah.
So I have two questions. First is what is the ocular follow-up? Do any of these patients need a redo surgery? And second, in a related note to what Dr. Tityal has said, you said, sir, as early as possible, the patients have to be operated. So do pediatric patients who get lens implantation done, with the increase in the growth of the eyeball, will the child need a redo surgery? And is there a sweet spot age-wise when the optimum surgery can be done so that the patient might not need a redo surgery if at all?
Yeah, very valid point, very useful point actually. If the child is less than, normally what happens that 99% of the ophthalmic growth occurs by the age of 2 years and close to 100% by the age of 3 years. Beyond that, very minimal change happens. It may happen in some, it may not happen in majority. So if we have to do a lens aspiration and put a say endocapsular ring to stretch the bag, that is very much, you can manage it later also, so you can do that. But if you have to fix the lens, it is always advisable to do it after 4 years of age. Still, if there is any change in axial length, because these are Marfan's cases, these children will have good vision for near. So that will prevent them from having amblyopia. That is important. So for distance, they can be given correction on spectacles as well. So that is something that is very much doable. Occasionally, yes, in some of the cases wherein just an endocapsular ring has been put and the subluxation increases further, then since it's a progressive disorder, then in that case, the whole capsular bag and the lens gets decentered on one side, maybe surgery done at the age of 3 years, 4 years, 5 years, and at 15 years of age, the whole thing comes onto one side. Then in that case, yes, you have to do a redo. Okay, thank you very much.